So, welcome everyone. Thanks for showing up. For those of you that don't know me or just forgot, I'm Jake Rogers, current president of SOA, and I'm happy to kick off our Ortho Trauma series. This is just going to be board members and anyone a part of the club that wants to put together a presentation about something in orthopedics. We don't get a whole lot of that sort of educational stuff in our first 2 years, so it's always good to learn on some stuff that we want. And our first one is going to be on acetabular fractures by our own VP of SOA, Jacob Frisbie. He prepared one, and if you guys have any questions as he goes along, feel free to ask questions. Otherwise, Jacob, take it away.
Sure. All right, let me get my screen shared here. All right, so today we're talking about acetabular fractures. Like Jake said, I'm Jacob, VP of the club here, and yeah, we're really excited to get going with the trauma series. And yeah, like you said, anybody that wants to put something like this together, we'd love to do it. Yeah, it's just not something that we get a lot, so it's exciting to get to do this. So hopefully we can have some fun today. So we're going to go through some general info about acetabular fractures, some anatomy review, and I think preview probably for some first years. I don't know how many of y'all have had anatomy previously, but go through the anatomy, the types of fractures and how they occur, treatment for these types of fractures, outcomes, and then a case at the end. So this guy, this is what most people think of when they think of orthopedic surgeons. So I don't know if it's true or not, whatever, but you know, let's just try to have as much fun today as this kid is having. All right, so just some general info. Basically, why should you care about this topic? So my disclaimer here is pelvic fractures are not the most common orthopedic injury that requires surgery. ACLs are by far the most common. But in terms of pelvic fractures themselves, one study showed that acetabular fractures do make up 62% of all pelvic fractures. So even though this is a uncommon thing, it is the most common of the uncommon things. So you will definitely see this in residency, maybe even in rotations. So doing this today, hopefully you can get an idea of how to talk about it. You've seen this before, and you can impress the residents and the attendings that you talk to about it. So let's get into our anatomy here. So this is our right hemipelvis. So first off, this is our acetabulum, right? So this is the socket joint of the socket part of the hip joint. So this is our acetabular notch. It's also called the cotyloid fossa. Some other real important things that we need to know here. So this is our superior pubic ramus and our ischial ramus, ischial tuberosity back here, ischial spine, greater sciatic notch, which is where the sciatic nerve passes through. So that's going to be some important pathology that we think about with these types of fractures. We have the ASIS, AIIS, iliac crest up here. And in terms of just the anatomy of the acetabulum itself, we consider this front part here to be the anterior wall, and the back part here to be the posterior wall, and the superior part here to be the roof. Okay. So now we just add in some soft tissue with that, as well as the femur. So again, we have this cotyloid fossa here, and typically it's filled with some fat, but it's also the attachment point for the ligamentum teres, which is the main ligament attaching the head of the femur to the pelvis. We have the labrum here as well, which is a real important structure when we think about this, because basically it's deepening that socket. So it's keeping that hip joint stable, and any disruption in that is going to lead to instability. We can also see the obturator foramen here covered by the obturator membrane. And this is going to be important just kind of as a landmark as we go through some radiology for this stuff. And then again, here we've got the three main ligaments. They've all been cut, but just kind of the idea. So we have the iliofemoral ligament, the the pubofemoral ligament, and the ischiofemoral ligament down here. And these are all going to be just parts making up the hip capsule, the joint capsule itself. And then the transverse acetabular ligament here that's just kind of connecting in between these two ends of the labrum there. So we've got basically the idea with the acetabulum is that it's supported by two columns of bone. So all of the weight from the femoral head sitting here is distributed between these two columns. So we have the anterior column here. So we're looking lateral to medial here, right? So this is the outside. So the anterior column is going to be mainly the pubic bone, this anterior portion of the ilium, and kind of right down the middle of the acetabulum here. And then the posterior column is just going to be that posterior part of the acetabulum. We can see that ischial spine right here as well, and then the ischial tuberosity, ischial ramus, all of that. So we can see the same thing here from the inside looking medial to lateral now. Same sort of area. So yeah, basically, like I said, just two columns of bone, anterior and posterior columns that support the weight going through that acetabulum. So we've got fracture classifications here. So the main way that we classify these is according to the Judet and the Les Tournelles. That's French. I don't speak French. That classification. So we have 5 elementary fractures. So we have the anterior wall fracture. So that chip off of that anterior wall, posterior wall, an anterior column fracture, posterior column fracture, and the transverse fracture. And then along with that, we have 5 associated fractures as well. So 10 total classifications of these. So the first associated is a both column fracture. So both the anterior and posterior column and the posterior wall, a transverse plus a posterior wall, anterior column plus a posterior hemitransverse. So we just have partially transverse on that posterior side there, and then a T-type. So this kind of goes along with the way that the bones fuse. So the acetabulum is made up of all 3 of the pubic bones, or sorry, all 3 of the pelvic bones. So the pubic bone, the ischium, and the ilium all come together and fuse in this sort of a manner. So the way this fractures is kind of right along those lines. So how do these fractures happen? So basically the fracture etiology depends on the age of the patient. So with younger patients, we typically see high energy traumas like a motor vehicle accident and that sort of a thing. With older patients, it's typically low energy trauma with fall from a standing height and that sort of a thing. So the type of fracture that we end up getting is really dependent on 2 major things. So the force vector and the position of the femoral head. So if we think about, if this is our acetabulum, right? And this is our femoral head, greater trochanter is out here, it's our neck. So if it's sitting in here, the position of this femoral head as we're getting hit will change the way that the bone fractures. So say that you are completely flexed at the hip, right? And you get hit down here, basically at your knee, it's going to shear off on the backside. Does that make sense? You guys can chime in here and tell me if that makes sense.
That makes sense.
Anyone? Okay, great. So yeah, like I said, force vector and position of the femoral head. So we can see on this picture, in this case here, we have internal rotation of the hip. So this is our anterior posterior side. So here we're internally rotated. So this is our greater trochanter. So in this case, if we get hit from the outside, the force vector is going to be coming this way, right? So that totally changes as we move the hip where that fracture can happen. And then one other thing is just the bone quality too. So in cases of osteopenia and stuff like that in older patients, that can really change how the fracture happens because of, just having weaker bone can lead to more in-depth fractures. So now we'll talk about some radiology. And I don't expect you guys to know a lot of this stuff. It's something that we don't get a ton of, but hopefully we can go through it and it'll make sense. So this is our AP view of the pelvis. So like the name implies, inner or posterior. So we're looking from the front to the back. You can see from the picture here, front, looking to the back. So with this sort of a view, it allows us to inspect a lot of different anatomical points. So the first one, we have the iliopectineal line here, which corresponds with the pelvic brim. We have the ilioischial line here, all the way down. And that corresponds with kind of the posterior side. So this iliopectineal line is part of the anterior column. The ilioischial line is corresponding with more of the posterior column. The next one is the teardrop. So right here, you kind of see this little thing that looks like a teardrop. That it corresponds with that acetabular fossa or cotyloid fossa, where the ligamentum teres attaches at. Next one is the anterior wall. So this one is really kind of hard to see. But if you can see right here, the start of this line, and then it just very faintly, you can see that it extends down through here. That's going to be our anterior wall. And then our posterior wall, again, same sort of a thing. You see it starting here and then just faintly see that it extends down through here. Same thing on this other side. You can kind of see the posterior wall a little bit better on this side, just kind of extending down through here. The next one is the roof of the acetabulum. So that's going to be up here, that kind of superior side of the acetabulum. We have the pubic symphysis, so where those two pubic bones come together. And with that and this SI joint here, the sacroiliac joint, basically what we want to see is that there's not, compaction together too much or that they're separated too much. That is definitely pathologic and is bad. We can see the lesser trochanter here as well. The lesser trochanter isn't going to be as important in terms of the fracture itself, but it can give you an idea because basically the idea is that it's a posterior structure, which means that if you externally rotate, say this side, you will get to see more of that lesser trochanter than what you would see on this side. So that would be indicative of a dislocation that could be associated with a fracture, specifically with the anterior wall. Same thing would be true with the posterior wall. If it's internally rotated, you'll see less of this since it's a posterior structure. So that would be associated with a posterior dislocation. So again, this is just an unlabeled version of that. So we have the iliopectineal line here, the ilioischial line. We have CR obturator foramen here, not on the list, but important structure just as a landmark. We can see the posterior wall back here. Can very faintly see an anterior wall here, a little bit easier to see on this side. We have our roof up here, pubic symphysis, SI joint. All right, here's where things get a little bit confusing, but hopefully I can explain it in a way that makes sense. So this first view, that's an oblique view, is the obturator oblique view. So what we're doing is we're turning the patient 45 degrees, still shooting the beam at 90. So what we're looking at here is the outside of this affected side. So anytime that we are looking at this, we're trying to figure out, okay, the affected side, right? So in this case, we're looking at the right. So we can see in this view, obviously it's named the obturator oblique because we can see the obturator foramen very clearly on that affected side. So with this view, just with the orientation, the main things that we're looking for in this are going to be our anterior column, which is going to be all of this here, and then our posterior wall, because we can see that very clearly when the pelvis is turned like that. Some other things we can see too, like I said before, obturator foramen, the pelvic brim and the roof of our acetabulum here. The next one is our iliac oblique view. So this one, we are turned at 45 again, but this time instead of looking from the outside, we're looking through to the inside. So again, we're shooting this from the left side, but we're looking at our right pelvis here. So with this one, we're able to see the posterior column very clearly. So all of this here, you can see that very clearly. And then we can see our anterior wall very clearly as well. So it's really nice that we're able to see all of this ischial wing back here as well, and see if there's a fracture back here that's going to be affecting this greater sciatic notch, then we have to worry a little bit more about sciatic nerve damage. The last modality or view that we can get is a CT. This is kind of the gold standard for this sort of a thing. It allows us to view the anatomy in layers. I don't know how much all of you have had with CT scans previously, but basically the idea with this is that we're taking basically a bunch of sequential x-rays. So the idea is we're looking from the patient's feet, looking up. This is our anterior, this is our posterior. So what we're doing is we can visualize the anatomy in layers. So we have a picture, and typically we'd be able to scroll through that, moving superior and inferiorly to be able to see what happens throughout the layers. And with this, we're really able to see some things that would be missed otherwise with just a plain radiograph. So we can see femoral head impactions. So basically, if you think about that femoral head, it's hard. If it hits something else that's hard, really hard, that can flatten that surface a little bit, and that's what that impaction is. Same thing with the articular cartilage impaction or marginal impaction as well, where that femoral head is hitting against the articular cartilage along here, and can kind of cause that to flatten out a little bit. We can also see intra-articular fragments. So if we have a comminuted fracture and we have a piece of that gets stuck inside the joint, that's going to cause problems, but is not really able to be seen on a plain radiograph very easily. We can see non-displaced fractures as well. So a fracture that there's definitely that fracture line, but it hasn't moved, and like the name implies, been displaced. So very easy to miss that sometimes depending on the angle with a plain radiograph, but much easier to see that with this sort of a view. The last thing would be a disruption in the articular surface. So if there's a shift, a fracture that causes a shift where you have kind of a sharp edge that's sitting inside that joint, again, it's going to be disruption of that, that surface. It's supposed to be smooth. So you can basically just get grinding along that, and you're going to end up with arthritis from that. So we want to make sure that we correct that once we go in to fix it. So here's just some pictures of what I'm talking about. So we have the marginal impaction here. It's this kind of more dense area here where the femoral head hit that articular cartilage, and it's kind of caused it to flatten out and get a little bit denser there. We can see that incarcerated fragment or an intra-articular fragment here, where part is just hanging out in the joint space, that we want to make sure that we get that out to prevent long-term damage. And then same thing here with the femoral head impaction, just kind of a denser area of the bone that is not supposed to be like that. Like you can see here, it's supposed to be pretty uniform, but we can see that the cartilage and the bone there has been damaged. So here's my quick tip. Y'all can do what you want, but this is kind of how I approach it. When you go through a radiograph with somebody else, here's some things you should do. So start broad, just tell them what you're looking at. Run through your anatomy. Do you see disruptions? Do you see signs of specific injuries? Or is the anatomy normal, that it doesn't warrant something being on your differential? So an example would be, this is an AP view of the pelvis. The iliopectineal line and ilioischial lines are intact. I don't see any disruptions in the anterior posterior walls, right, etc. So that's kind of my way of approaching this. Just go through it, you know, as sequential as you can. That way you don't miss stuff. And just as a kind of plug for later SOA events, Brian Hops is a PA with DMOS, and he typically comes in and will go through kind of his approach to radiographs a little bit more in depth than what I'm doing with his Is It Broke lecture. So stay tuned for that. So treatment of these fractures. So typically this is based mainly on age and activity level. So do they have underlying conditions that would prevent them from being a candidate for surgery? What's the bone health like? Do they have osteopenia, like I mentioned before, osteoporosis, that would weaken their bone and maybe make certain types of fixation not as stable? And what was their activity level like prior to their injury? I mean, you could have an 80-year-old that's out playing golf or playing tennis pretty regularly, or you could have an 80-year-old that's wheelchair bound. So the goal with most orthopedic surgery is to restore the anatomy first and foremost, and to restore their activity level to as much as you can as what it was previously. So our three main treatment options for this, we can either do protected weight bearing, we can do ORIF, open reduction internal fixation, or we can do a total hip. So with protected weight bearing, 6 to 8 weeks of toe touch weight bearing with crutches. This is typically done in people with high operative risk, like I mentioned before, with pre-existing conditions that would prevent them from being eligible. Morbid obesity, same sort of idea, but also just having that extra weight on an injured joint and on an injured or on a fixation can cause problems. And then the last thing is a minimally displaced fracture, typically less than 2 millimeters. And this is most commonly done with posterior wall fractures that are displaced. The main thing that you want to do though, do a fluoroscopic exam under anesthesia to make sure that that joint is stable. Take the hip through all sorts of range of motion tests just to make sure that it truly is stable before you let them go and say, yeah, do protected weight bearing. So that nothing happens. You know, don't want them to be walking around, accidentally put weight on it, and it pops out and you get a worse fracture. So making sure that things are stable is really important. Our next method is ORIF. This is our most common treatment method in younger patients and stable patients. Keeping in mind that stability, because in a lot of these patients, they do have polytrauma. Especially if somebody was in a car accident or that sort of scenario. Obviously, we need to make sure that they're stable before we take care of this sort of a thing. So this is indicated, obviously, in fractures with a large displacement where we need to bring things back together, or where there's a high level of instability. Other indications for this include recent injury. So the kind of rule of thumb with this is that less than 3 weeks post-injury, you can do this sort of fixation. Otherwise, if it's been more than 3, they're going to go back to protected weight bearing. Same thing with infection. If it was some sort of an open fracture that there was an infection involved, you're going to send them on protected weight bearing, deal with that infection, and then go from there. Our last method is a THA, total hip. Most commonly done in older patients, especially those with osteopenia, that low bone density that would affect their ability to have an ORIF done successfully, as well as pre-existing osteoarthritis. If they already have issues and they're a candidate for a total hip anyway, why not just do it all at once? So ORIF, in addition, can be done depending on the severity here. So we can see with this one, we had a plate done on that pubic symphysis here. It looks like we had a little bit of ORIF done around the acetabulum before the total hip was done here. And then we also have these screws going through the SI joint as well. So this looks like it was a pretty severe trauma that happened to this patient. And in addition, this can be done in younger patients if they have post-traumatic arthritis and they just can't walk on that hip anymore, and it's causing them too many problems. This can be done in a younger patient. So outcomes. This looks like a pretty nasty fracture. So what does life look like for people that have had this? So consider this. Got a 21-year-old male college football player, tackled from behind. His knee was on the ground. His knee and hip are both flexed at 90 degrees. The tackler lands on this guy's back. He feels a pop in his hip and he can't walk. He's taken off the field in the cart. So imaging is done, shows posterior wall fracture, hip dislocation, and a labral tear. He also had a nasal fracture from hitting his head forward against the ground as he went down. So that kind of begs the question, can this guy ever play again? Some of you might know who I'm talking about already. Talking about this guy, Tua Tagovailoa, Roll Tide. So he was injured last year and had all of this happen to him, but ended up getting drafted 5th overall in the NFL draft, making millions of dollars. I'd say he's doing pretty well. Obviously, younger patient, better outcomes associated with that, but this is definitely something that you can return from, but definitely depends on the severity as well. So typically, fixation of the fracture is sufficient in restoring hip stability after this sort of an injury. And just kind of an orthopedic pearl here, something that you should take with you for sure out of this. Anytime the hip dislocates, there's almost definitely going to be a labral tear associated with that. And part of that is just because that labrum, like I said before, deepens that hip socket. So really the only way for that femoral head to come out is if there's a disruption in that. But again, as that is coming out, it typically is going to wear over that and tear it. So in certain cases of anatomic variation with this, like hip dysplasia or kind of weird like retroversion of the acetabulum, you may have to repair the labrum to restore stability, but typically, like I said, fixation is going to be sufficient to restore stability in this. 75 to 80% 10-year survival in patients who undergo a total hip. And this would be a lot higher if it wasn't for the age of the patients typically being the factor that is affecting this. Total hips are one of the safest procedures. It's done all the time. We figured out how to do it really well, really safe. So this is a really, really good outcomes in patients who have this done. Poorer outcomes are associated with people who have multi-system polytrauma, people of increased age, when you have inadequate reduction around the articular surface, so that surface isn't smooth any longer. Injury to the articular surface of the femoral head with an impaction. Same thing with the articular surface of the acetabulum as well. Same also with post-traumatic arthritis, you can have poor outcomes associated with that. So we'll go through a case here. So set this up. You matched into your dream residency program, and your first rotation in that is with the trauma service. So you have a 19-year-old male comes in with right hip pain after a car accident, motor vehicle accident, and inability to bear weight on that side. So can I get a volunteer who wants to just go through this radiograph for me quick? Don't make me call names, y'all.
I can give it a shot.
Thanks, Ben.
Let's see if I remember any of my anatomy, but
just start
broadly,
basic. Tell me what you see.
Broad general, it looks like all bone structures are there, present. We have that pelvic inlet rim looks fairly intact. There may be something on the patient's left side, kind of a notch near the acetabular head there, or acetabulum there.
Right here?
Yeah.
Okay.
And the pelvic outlet, I can't remember the anatomy off the top of my head, but.
So you were saying our iliopectineal line looked good, right?
Yeah.
So we're looking mainly on the right side, but you're good looking at both sides. That's a very good thing to do. So our iliopectineal line looked good. And our ilioischial line, you said, looked intact too, right?
Yes.
Okay.
And then we have our teardrop. It's pretty evident on our right side,
Mm-hmm.
not so much on the left side, but again, we're looking at the right hip mainly here, so that might just be rotation or something like that due to an artifact of radiograph. I'm definitely seeing like a flattened edge of the femoral head, it kind of looks like, or kind of like an impacted little, yeah,
along
it
there.
doesn't look smooth on the acetabulum, kind of at a 2 o'clock position.
Yep. And what view of the pelvis is this again?
This looks anterior posterior.
Okay, great. Anything else you want to go through at all?
Not that I can think of.
Sweet. All right, we'll go to the next one then. So who wants to be next? Dallin's saying nose goes, it looks like. Taylor, you want to go for it? Taylor, I think you're muted.
Can you hear me now?
Yeah, you're good.
All right, so we're at this is oblique view looking at the patient's right hip, like looking into the right hip here.
Okay. And is this an iliac oblique or a obturator oblique view?
Want to say this is an obturator oblique, but correct me if I'm wrong.
This would be an iliac oblique. We're looking at this right side.
Sure.
We can see the obturator on the left side here. So we're looking into the inside, right?
Gotcha.
Okay.
But it looks like, so I'm taking a look at the kind of the acetabulum joint there. I'm not really sure if I see any gross abnormalities, but looks like the kind of the posterior wall might be a little
Along back here.
Yeah.
Okay. But we see, what do you think about the anterior wall?
Yeah, I was just trying to figure that out. I mean, it's definitely not, it's wavy.
Yeah, definitely. And that's how that's supposed to look. We just don't see any big fracture lines within that. That's a real disruption, but a normal kind of wavy appearance like this is pretty normal. So you mentioned a little bit of kind of weird back here, but
Yeah.
everything else back here looks pretty normal. With this view, we're looking at the posterior column and the anterior wall mainly. So nothing huge that's sticking out here with this view. Jake, I'll throw you the softball on this one.
Awesome. So this one's the obturator view, right?
Yep.
Yep. It's the only one left. So right out of the gate, I see a small, dark, thin line on the left side of the screen, kind of next to the acetabular head. Sorry, femoral head. Keep going left. Yeah.
Here?
Mm-hmm.
Okay.
So that's something to note.
And what would that be associated with? Does it look like?
Let's see. In that view, is that the posterior wall?
You got it.
Yeah.
Yep.
So that is what I would assume is the cause of most of his pain. Everything else looks pretty good. Pelvic brim, obturator. Yeah, I'm gonna go with that final answer.
Yep, I agree. So we definitely see a posterior wall fracture back here. And so with this view, the main things we're looking at again are that posterior wall and the anterior column here. So we don't see anything here, but definitely see that. And this, I just want to make the point of, it's really important to make sure that you get multiple views, no matter what you think the fracture is in. Make sure you get multiple views, because from here, we can maybe say that we see something back here, but in both of these views, it's going to be really hard to make this diagnosis. So just making sure that you get multiple views, don't rely on just one. So the last one here is our CT. Pretty clear back here that we have this posterior wall fracture. So again, different imaging modalities, different views is going to be really important in any diagnosis that you're making, just to make sure that you don't miss anything. Even if there's a very, very apparent fracture, you may miss something if you don't get a second view. So these are my references. Any questions?
I've got one for you. So what frequency do you see like a femoral neck fracture associated with the posterior dislocations here or fractures?
Yeah, so that's typically something that will occur in an elderly patient more than a younger patient, just because they have more severe bone loss, and the bone's a little bit more brittle. But certainly if there is, a high enough energy trauma, it could definitely happen. But typically what you're going to see here is going to be that acetabular fracture. And it really, again, depends too on the force vector of things as well. If you're getting hit from the outside in from that greater trochanter, just falling on the side of your hip or something like that, it's going to be more likely that you're going to get more of a medial impaction. And that can lead to a medial displacement of that femoral head too. But yeah, it's typically going to be in the elderly that you see that. Anybody else?
Jake, when you were doing your research, did you see, if you're an orthopod, are you commonly working alongside vascular surgeons in this area? Is it, are you heavily concerned about the vasculature here, or does it kind of just heal itself as you
Yeah, so
approximate everything back together?
there's two main vascular concerns with this. So you have it's called the corona mortis. It's a kind of an anastomosis between the internal iliac and something else. Got to review my anatomy. But anyway, that goes along the inside of the pelvis there. So if you get a fracture, typically you see it with a transverse fracture, but anything that's affecting kind of that medial portion, or not medial, but the middle portion of the acetabulum, you can have some damage there. The other thing is going to be the medial circumflex femoral artery can be damaged as well, and that's our main supply to the femoral head and neck. So if that's damaged, you may end up with some necrosis of the head and neck. So those are our two big ones. And then, like I said, in terms of neurological concerns too, the sciatic nerve is going to be our big concern with that. So does that answer your question, Ben?
Yeah, thank you, sir.
I do have a quick question for you, Jacob.
Sure.
As you were doing this, if I wanted to learn more about these kinds of fractures or things related to it, which resources did you find as you were putting this together that you found to be the most useful?
Great question. So I was actually going to bring this up. So I did most of my research and found probably 95% of this from Ortho Bullets. Ortho Bullets is awesome. Basically, you just, the website you go on, you can search, different procedures, different injuries, different even approaches, anterior, posterior approach to the hip, those sorts of things. And it just gives you some reading for it. You get pictures, and it includes some quiz questions, stuff like that. And then they also have a podcast as well that's pretty well done. They just basically go through in an audio format what's on the Ortho Bullets website, and then they have like 5 to 10 quiz questions at the end based on the topic. That would be pretty high yield stuff for not necessarily med school boards, but for the ortho boards in the future. So that's really the best resource that I found to learn a lot of this stuff. And if you want to put something like this together, it's a great resource to use. Anybody else? Mike, I can't hear you. Might be on my end, I'm not sure, but
Nope, I don't think it's on. I think it's on his end.
shoot.
Yeah. Feel free to type it too if you need.
Yeah, you can type out your question if you want to. Anybody else? I mean, even just, I'll take feedback right now. Like, I'll probably do another one of these at some point. Was this helpful? Is there anything else I should include? I'll take feedback now too if you guys want.
I guess I'm just a little curious want to hear a little bit more about your background, like where you learned a lot of this stuff. Was it just studying, or was it a research project or past job you had?
So most of this has just come from doing my own research with the Ortho Bullets resource. A little bit has come from some previous case study stuff that I did, but the case study is what initially sparked my interest with it, but a lot of the actual learning that I did came from Ortho Bullets and just doing stuff on my own. Sometimes you just got to be an ortho nerd, you know? Just need a break from regular school.
Yeah, that's sweet.
Okay, so do THAs increase the risk of an acetabular fracture? So I think that it would actually decrease, because typically a THA is going to be done in somebody that has arthritis, but maybe could potentially have osteoporosis on top of that. So if you're putting in a metal implant, the risk of actually fracturing the acetabulum itself is going to be pretty low. But there's certainly some concern with the procedure of if they do have really, really brittle bones, that you could induce a fracture as you're doing it, that you could, when it's done, you use a reamer. Right? I don't know how many of you guys have seen this in the OR before, but you use a kind of a big burr that's shaped in the shape of the acetabulum to kind of just smooth out the inside, get rid of the cartilage and all the gunk that's in there so that you can start fresh. If you do that too far in, you're going to have the risk of penetrating through the other side. But to actually, get at your question, no, it should not increase the risk of an acetabular fracture itself.
Can you hear me now?
I can hear you now. It's great to hear your voice.
Sorry. Yeah. So it's not one of those things that, like, you're taking a history of a patient and they come in, they're like, hey, I have hip pain. I had a total hip done like 6 years ago, and you're thinking, oh, okay, it could be like a paraprosthetic acetabular fracture or something like that. It's not one of those things that's commonly associated, then it doesn't sound like.
I think I missed the middle part of what you said. So they came in, they had a total hip done, right?
Yeah, and they're like, okay, I'm having hip pain. And so while you're taking that, that's not something that like cues in like, okay, it could be a paraprosthetic acetabular fracture, just a fracture around the prosthetic.
Yeah, it totally can happen. You can still get an acetabular fracture that happens.
But that's not like a common thing that you'd start thinking in a situation.
No, it's not necessarily a common thing. Just because you had a total hip wouldn't necessarily preclude you to being more at risk if you had a fall or something like that. But I mean, it's still something you should think about. There's still bone surrounding that implant, right? So, it's something that can happen, but I wouldn't necessarily say that it increases the risk. Does that answer your question fully?
Yeah, for sure.
Sweet.
Well,
Sweet.
it's just, I feel like there's so many things like that in ortho, well, just in medicine in general, where there are so many hot words, where like they start saying this and you see something in the history and you already know before you
right.
see an X-ray. So I was just kind of trying to connect those dots.
Yeah, absolutely. Anything else from anybody? All right.
Just kind of a general question. Sorry. How often are you guys, Jake and Jacob, and planning on doing stuff like this? What was kind of that? Just kind of whenever.
I would love to do one like once a month or so, if it's possible, if we can make that work. But you know,
Yeah, no, this
it's
is really good.
mainly dependent on if people want to make them. I mean, it didn't take a ton of time for me to do it, but you know, it took some time. So I understand that people have a lot of things going on, but yeah, if we can do this once a month or so, that'd be awesome.
I thought
think
it was
once a
great. It's
month
just
would be
like
cool.
we can either kind of fumble through stuff here and like learn about it here, or while on rotations.
Yeah, exactly. Right.
Here, I guess.
Yeah, it's better to fumble in front of your peers, right?
Right. Well, cool. Thanks for putting it together.
Yeah, man.
And if there are no more questions, Jacob, thanks again. Great job on your presentation. And that concludes our first, and again, what we hope to be a series of orthotrauma presentations. Thank you all for joining me and all of us, and have a good weekend.
Thanks, y'all.
See you next time.